Welcome to the AA Podcast, our little corner of the web where we are not afraid to discuss tough questions like,
when did nutrition, health, movement, and stress management become alternative medicine?
Where we embrace challenges in all aspects of life to become healthier and stronger versions of ourselves.
And where food and movement are the best kinds of medicine, and cooking meals at home is a revolutionary act.
Hello, and welcome back to another episode of the AA Podcast. This is Ashley Olson.
And I'm Andrea Crane.
We are back once again with our amazing guest, Josh Wageman. Got it right this time, right?
Woo-hoo.
That's right.
Okay. But his face was like, no, she didn't say it right. No.
Wrong again.
Josh, if you did not listen to last week's episode, I highly recommend you just stop right now. Go back and listen to that first part because we're continuing our conversation on all things cholesterol and lipids and all the things. Things that are way above my knowledge, but Josh does a great job of breaking it down. And he is releasing a book here on February 18th that just kind of simplifies and helps the basic person like myself understand the pathways and how things are working. So, but before we get into that conversation, we are going to start with our weekly Bible verse as always. And Josh is going to join us this week, which is exciting. So mine is coming from Psalm 25, 4 and 5. And it says, "Show me your ways, O Lord. Teach me your paths. Lead me in your truth and teach me. For you are the God of my salvation. On you I wait all the day."
And mine is coming from my own personal Psalm 27, 27:5. "For in the day of trouble, he will keep me safe in his dwelling. He will hide me in the shelter of his sacred tent and set me high upon a rock."
Love it.
And our first guest to do so, Josh, go for it.
Yeah, no, I am honored. And so given that we're probably going to touch on the complexities of cholesterol homeostasis in the brain today, I thought it would be appropriate to read from Ecclesiastes 8:16 and 17, which says this. It says, "When I applied my heart to know wisdom and to see the business that is done on earth, how neither day nor night do one's eyes see sleep. Then I saw all the work of God, that man cannot find out the work that is done under the sun. However much man may toil in seeking, he will not find it out. Even though a wise man claims to know, he cannot find it out." And that was King Solomon. He was a pretty smart guy. That was his way of saying the more you know you don't know. And so he beat Aristotle to it, I think.
Yeah, absolutely.
But anyway, there's a lot of things that we know. There's a lot of things that we might think we know, and there's a lot of things that we're keep on trying to find out. And it's a beautiful privilege to explore these things. But as we get into this topic, I think we all need to approach it with some humility because there's a lot we don't know.
Humor and humility, yes, because the older we get, the dumber I am. I don't know. It's like things, the world expands, and I'm like, oh, well, there's more I didn't know anything about. So, yeah.
That's
So,
for
hey,
sure.
Josh, I was wondering as we get started today, could you kind of reset for us? Could you kind of come in? So, for those listeners that may have a weekend between, could you kind of reestablish where we're at in terms of the home security system and the brilliant apt metaphor that you're using here, just for our listeners to kind of get caught back up, and then we'll go from there.
Absolutely. And, the more you hear this stuff, the more it makes sense. And
Agreed.
also, hey, on February 18th, you'll be able to get the book that says all these things too. But for everybody who doesn't want to have heart attacks, strokes, and dementia, I say, hey, I want you to have a great home security system, and I want you to live in a safe lipid neighborhood. Your home security system has 4 basic pillars: normal blood sugar, normal blood pressure, keep inflammation low, and don't smoke or do drugs. Those are bad. But then your lipid neighborhood is your cholesterol panel, because every ApoB containing particle, which most of those are LDL particles, are potentially criminals that can invade your physiologic dwelling. And the Lp(a) particles, if you pick the wrong parents with that guy, those are the potential felons, because per particle, they're about 6.5 times as likely to cause mischief as your run-of-the-mill LDL particle. But people don't live on paper, right? We can look at your lipid panel and be like, ooh, looks like you live in a rough inner city, but That doesn't really tell us the whole story. And so, do we have better ways of identifying whether or not you've been broken into? We do. And so, one of my catchphrases is got plaque, get a CAC, which is a coronary artery calcium scan. I call it the colonoscopy of the heart without the nasty pregame show, because you lay down and a low dose CT tells you if there is calcified plaque in your coronary arteries, which is a late finding in the whole process. And then, if you have been broken into, do you want to keep living in the same neighborhood that got you broken into? Or do you have the option of moving to a nice, safe, gated community with fewer criminals? You do. And we'll talk about in a little bit some of the ways that we can do that, and
Mhm.
stabilize plaque and
Mhm.
even potentially regress plaque if you've been broken into. So that's kind of my paradigm for not having heart attacks and strokes. And that does extend into the dementia realm. But as we'll talk
Mhm.
about later, cholesterol in the brain is it's a wild one, and there are some
Mhm.
different things in the brain that we don't see below the brain.
Mm,
Cool.
that's
All
awesome.
right. Well, so there are. I really, really was excited for you to address this because, back, gosh, it's probably been 15 maybe years ago now. There was we just started to some of us kind of on the on the fringe, I guess I'll say, started to say, hey, you know what, these cholesterol numbers, they're not exactly what they seem, right? The HDL, the LDL, I think there's probably a little more to this. And um there was this idea brought forth about the ratio, right? The almighty ratio. So if your ratio between the LDL and the HDL were less than, I don't know, I think 3 or 4, then, you were doing okay, regardless what your actual, objective numbers were. So, can you speak to that a little? Because I think that there are still people laboring under that assumption, and it's even more complex than that, right? It was a place to start, but
Yeah, and I'm glad you brought that up. And so I'm going to take just a step back to reestablish the purpose of these
mm,
things and what
great.
people typically get taught in med school, in PA school, and MP school, in any medical program.
Hmm.
Because I've precepted them all. I do adjunct faculty work at various med schools and medical programs, and
Hmm.
basically everybody gets taught this: LDL bad, HDL good. Everybody take a statin. That's pretty much
Hero
it.
and loser. Yep.
Yeah, and that makes us need Zofran, right? Because that's just
Right.
nauseating rhetoric.
Right.
And so anyway, so that's what we get. And so remember, the ApoB family, which the predominant particle in these is going to be your LDL particles under normal physiologic situations, is going to be your LDL particle. But they're mailmen, right? Mailmen aren't
Hmm.
necessarily bad dudes as long as they just deliver the mail, which is primarily triglycerides, a few phospholipids, some fat soluble vitamins along the way, and then go home to the liver. But if
Hmm.
that mailman runs a truck in your arterial wall, well, that's a bad mailman, right? And then you need to address the corrupt workforce. Okay, so LDL particles are not inherently bad, but they can be, if the mailman,
Hmm.
ends up in the wrong place. Okay, so that's the first one. Now, the ratio, this goes into the kind of triglyceride to HDL ratio, okay? Because
Hmm.
HDL cholesterol, it does some really good things. And if you want to use the mailman neighbor, or the mailman metaphor, HDL is kind of like the police force, because they are
Hmm.
capable of taking one of these criminals that's invaded your arterial wall and, taking it to its jail cell in the liver, after it's
Hmm.
committed mischief. It's capable of doing that. HDL particles are capable of actually binding up lipopolysaccharides and lipoteichoic acid if it's a gram-positive bacterium, and
Hmm.
helping function as a sink to clear those pathogens from your
Hmm.
circulation. That's good. HDL does a
Amazing.
number of really, really good things, but just looking at a static marker of HDL cholesterol in your blood panel doesn't tell you what it's doing or what it's not doing.
And it's a U-shaped curve too,
It is. And
which
so
is a whole nother can of
yes.
worms, I'm
And so
sure.
people with
Hmm.
really low HDL cholesterol levels, they tend to, have a increased risk of coronary disease. And I'll talk about why that is. But people with the really high HDL cholesterol levels, start getting over 80, even over 90, even over that,
Hmm.
you a lot of times see an increased risk of coronary disease in those people too. Well, why is that? Well, a lot of times those people have dysfunctional HDL particles. And this isn't for the people who aren't drinking a ton of alcohol, because that will increase your HDL, and don't do that. But there are certain people with genetic mutations and things like SRB1 and endothelial lipase and
Mhm.
hepatic lipase that can have really high HDL cholesterol, but they can have really advanced disease because, they got a police force, so they're just not doing anything. So you don't
Mm.
really know. And basically just looking at your HDL cholesterol or relying on your ratio to think that you're invincible, you're not. And so I'm still a big fan of, hey, do the same thing you would, got plaque, you don't know, get a CAC. And so, and a
Mhm.
lot of times I would have patients who I'd get pretty nervous if their HDL cholesterol was like 100 and they had a strong family history, and they
Yeah.
waltz in, they're like, oh, I don't need to worry about that. Like, my ratio is good. I'm like, oh, yikes. And I know I had one
Mm.
lady who had a CAC of over 1,000 who had an HDL cholesterol like 105.
Wow.
And I
Good
didn't get
grief.
the genetic testing to say, oh, are you SRB1 or Lip C? You're like,
Mhm.
well, no, but she had advanced disease. We
Yeah.
need to address that. So just the static marker of HDL cholesterol doesn't tell you anything about what it's doing or not doing.
Mhm.
Typically, a triglyceride to HDL ratio, if your triglycerides are high, that's insulin resistance, because the
Mhm.
mailboxes are
Yep.
full. The mailmen are
Yeah.
trying to deliver their triglycerides, but the mailboxes are full. So it's just another way that we can say, hey, this person's probably insulin resistant, which is not a good thing to be. So let's take care of
Mhm.
that. However, there are certain ethnic differences in triglycerides.
Oh,
People of
interesting.
African ancestry, they will
Mhm.
have normal triglycerides and normal HDL cholesterol a lot of times and be very insulin resistant. And there's something
Hmm.
called steryl CoA desaturase, that there's an isoform of that makes them have that phenotype. And so it's one of those things where in a person of Caucasian descent, typically an elevated triglyceride level will say, okay, yeah, you're insulin resistant. People have really high triglycerides probably have some sort of defect in lipoprotein lipase or one of the alleles that lead to lipoprotein lipase function. But at the same time, the HDL cholesterol itself, you're not sure what it's doing. Now,
Mhm.
what I'll go into a little bit is why we see HDL cholesterol being low, typically associated with coronary disease. And so what's interesting is if you have a ton of triglycerides around, okay, which,
Mhm.
insulin resistance in general, then what happens is your HDL cholesterol gets fat and fluffy with triglycerides. There's an enzyme called CETP that coordinates the
Mhm.
transfer of cholesterol from an HDL particle to the ApoB particle. And so when there's a
Mm.
ton of triglycerides that have come out on the ApoB particles, the HDL is like, okay, I'll take your triglycerides in exchange for my cholesterol. Problem is, when there's too many
Mm.
triglycerides around, the HDL particles get all fat and fluffy. It's kind of like, the police force. They're not going to pass their tests if you got this cop who's super, super overweight, right? And
Right.
so you got these HDL particles that aren't supposed to have a ton of triglycerides on them. But
Mhm.
what happens is your body's like, yikes, we need to do something about that. And so, in the attempted fat removal procedure by various lipases, what you're left with is a very gaunt, emaciated HDL particle. So it's like, all right, well, let's just do some sort of weight loss procedure on this HDL particle, but it doesn't
Mhm.
work very well, and so you're left with this really pathetic HDL particle. And your body looks at that as like, nah, well, let's just get them out of the workforce. And so your kidney actually comes in, and there's a couple of different proteins called megalin and cubalin that catabolize that gaunt, emaciated HDL particle. So when
Hmm.
this happens a whole bunch of times, well, what are you left with? Low HDL cholesterol. And so it's
Okay.
not telling you what the HDL cholesterol is doing or not doing. It's generally just a sign that you have way too many triglycerides around the clock. And then
Mhm.
over time, that leads to a drop in HDL cholesterol. If you're going to use HDL cholesterol for anything in general, but because there's always exceptions, there's people with low
Right.
HDL cholesterol that have a really functional HDL cholesterol. It's called ApoA1 Milano, and it's crazy stuff. Lipids get crazy. But in general, when we see low HDL cholesterol, it's kind of like the hemoglobin A1C of postprandial lipemia. When
Hmm.
you can
Okay.
have a normal fasting, triglyceride, 90 or so, but if your HDL cholesterol is 30, then probably every time you eat, your triglycerides spike way, 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 way up. And so you can kind of look at it as similar to, the A1C of postprandial lipid excursions in
Mhm.
general, but there's always exceptions. But that's typically the case, especially in
Okay.
our insulin resistant Western society. Um,
Yeah.
that said, it's interesting physiology for sure. I think it's interesting to
Mhm.
know why these things are related to various markers of disease. But at the end of the day, you don't know what your HDL is doing when you're looking at it on a blood panel. But in general, if your triglycerides are high and your HDL cholesterol is low, it's insulin resistance.
Yeah, and that's typically what if I see an aberrant cholesterol patterning, it's very much that
Yeah, and
in
what's interesting
practice.
too is, I mean, triglycerides, it'll say 150 is normal on a blood panel, and that's
Yeah.
really high. You start seeing accelerated cardiovascular risk at 100, probably even a little lower than that.
Mm.
And what's
Mhm.
interesting is if you ever run advanced lipid panels, where you get, an NMR spectroscopy or something called
Mhm.
an ion mobility, where you get your different particle subfractionations, it's actually triglyceride levels around 95. That's kind of an inflection point where you see it
Oh.
shift to a pattern B for bad, of
Yeah.
small, dense
Mhm.
LDL particles, typically even
Mm.
around 95. So I think our standards of triglycerides on your blood panel, it's like, oh, I'm at 148, I'm normal. Probably
Mhm.
not actually. Probably real, we have some work to do in general.
Yeah, I'm taking notes. Thank you. That's super helpful.
Yeah, because I
Um
think, I mean, you just hear about the numbers so much and you don't take into consideration the whole picture, which I think is just, I love how you're bringing that all together.
yeah. So um the next place that I would like to go if we can is the this issue. I see a lot of people you know who have elevated cholesterol panels, and sometimes markedly so. And in a functional space, I hear a lot of, well, my whole family has high cholesterol. Like, this is just how we are. And it's not necessarily that the trigs are super high, right? But it's the LDL in particular that's really high. The total cholesterol is really high. And it's kind of hard to parse out, well, is this a familial hypercholesterol situation? Is it genetic? Um and if so, like, how prevalent is that? And further, is do we need to be doing anything about this?
Yeah, yeah. So of all the things you see on a lipid panel, triglycerides are the most modifiable with lifestyle. If
Sure.
you're going to, Jack in the Box and Taco Bell every day and your triglycerides are through the roof, well, probably stop doing that.
Mhm.
Prioritize protein, eat real food. Knock it off, whatever you're doing, right?
Right.
But
Right.
what you're referring to is what we would call familial hypercholesterolemia.
Mhm.
And there's both homozygous familial hypercholesterolemia and heterozygous. Now, homozygous FH is a terrible disease. It's like 1 in 360,000 to a million. This is the reason why we know that, hey, if you live in too rough of a neighborhood, even if you aren't insulin resistant and don't have elevated blood
Mhm.
pressures and you have a perfect home security system, you're still going to get broken into if it's so severe.
Yeah.
And these poor kids, they're in the cath lab, before they're the age of 10, and terrible disease, right? And that's very, very
Mhm.
rare, fortunately.
Mhm.
But that's homozygous FH, very rare. I only had one patient ever with that. Now, heterozygous FH is a lot more common, and heterozygous FH is interesting because it's a phenotype. And so it is an LDL cholesterol of 190 or greater when secondary causes have been ruled out. Because there are certain things like
Mhm.
extreme diets, also nephrotic syndrome, certain
Mhm.
biliary obstruction if you have gallstones or whatever, untreated hypothyroidism. There's certain things that can lead to elevated lipid levels that once you correct that underlying cause, it goes down.
Right.
But this would be a phenotype of, hey, the person's LDL cholesterol untreated, we've ruled out the other stuff, is greater than 190. Now, there are
Mhm.
three different autosomal dominant alleles, so gene mutations that result in this phenotype. And so they would be the LDL receptor, ApoB, and PCSK9. Okay. And the reason why these result in elevated LDL cholesterol is because these are the three big players in clearance. So I've said that I want these particles to go home at the end of the day, and home is the liver. And so the LDL receptor is the primary means by which these particles, these mailmen, will go home at the end of the day. So I'm going to shift my metaphors a little bit to kind of paint the picture of what the LDL receptor does. So the LDL receptor is like one of those claw grabbers at the arcade. And guys, if anybody has kids out there, I have a 7-year-old daughter. She's adorable. But if you go to the arcade, those claw grabbers where you win the stuffed animal, and
Where you lose money. That's
I'm
real.
really
Yeah.
bad at those. My wife's actually
Yeah.
pretty good. But I like to go to this place called Wahoo's around here because you can pay
Mm-hmm.
like an obnoxious amount of money, but you're guaranteed to win. And
Oh.
I like being a guaranteed winner because I'm absolutely
Mm-hmm.
brutal at it. But anyway, so the LDL receptor is like one of these claw grabbers. And what it
Mm-hmm.
goes is it goes out and it pulls in the LDL particle and it recognizes the ApoB on it. So it's like a stuffed bear, Apo bear. And this is how I taught it to my
Mm-hmm.
daughter, and she can explain it pretty well to you. So it recognizes the ApoB bear and it says, okay, I'm going to grab you and pull you in. Oh, okay, that's good. So that's what typically happens. And the LDL receptor can recirculate hundreds of times over its lifespan. So the claw grabber goes out, wins you the stuffed animal. Great. All right, next person in line, get in. Yay, everybody's happy. Everybody's got the stuffed animals. Nobody's getting heart disease. Problem is, if something called PCSK9, which is proprotein convertase subtilisin kexin type 9, and when you can rattle that off without sounding like you're going to throw up, you've really arrived somewhere in the world.
Mm-hmm.
But anyway,
Mm-hmm.
so PCSK9 though, this puts your claw grabber out of order. So if PCSK9 comes along and it binds to the LDL receptor claw grabber, well, it actually leads to endolysosomal degradation of the LDL receptor in the liver. So it can't go back and recirculate. Uh-oh, what's happening? Kids are crying, the line's getting longer, nobody's winning stuffed animals, people are getting heart disease. So those are the three big players in clearance. So you want a good working LDL receptor, the claw grabber. It needs to
Mm-hmm.
recognize the stuffed animal, which has ApoB on it, the Apo bear. And then hopefully there isn't too much PCSK9 around putting your claw grabber out of order. And so
Okay.
if someone has a loss of function in the LDL receptor or a funky shaped ApoB, so you can't pick up the bear, or a gain of function where there's too much PCSK9 around, putting your LDL receptor out of order, that can lead to this phenotype of familial hypercholesterolemia.
Mm. Okay. Okay. And so is for folks well, do you have a sense of how prevalent that like the heterozygous
Yeah,
version
so
is?
and the thing is, people will have, LDL cholesterol of 200 or something and will have
Mm-hmm.
no autosomal dominant allele, right? So, these
Sure.
things are
Yeah.
often polygenic. And so 1 in 200 to 250 is one of these autosomal dominant mutations in general. But
Mm-hmm.
more often than not, you'll have somebody with that elevated lipoprotein little a, and they will have, also an LDL cholesterol that's quite high
Mm-hmm.
at the same time. And so that's really their issue. You'll see that quite a bit. And so, anyway, but it's not really necessary always to go and, oh, I'm going to go get genetic testing for LDL receptor, ApoB, PCSK9. That's and it's kind of a pain to get that
Right.
sometimes. And so
Well, and the things, the interventions, right, would be the same regardless of etiology, right? So whether it came from genetic mutations or whether it came from lifestyle, obviously we're going to quit the lifestyle, but patients will do what they're going to do. So what can be done about this? Like, let's
yeah,
say that someone has they've been broken into, proverbially
yep,
speaking, and
yep.
they've got plaque buildup, the positive CAC. Um, how do we address that?
Yeah. So, so you've got your, people don't live on paper, like I said. So you've gotten your CAC, it's positive, or and a
Mm-hmm.
CAC score of 300, you have equivalent risk even over 4 years of having, a heart attack, as someone who has
Mm-hmm.
previously had a heart attack. So 300 is just the
Mm,
whole, holy smokes, we need to do something out this big time. I'd say if there's any non-zero score, yeah, you've been broken into and hopefully the damage
mm-hmm.
is repaired, but that's kind of a scab. It shows that, your lipid neighborhood isn't quite so safe and maybe your home security system needs some addressing as well. And
Mm-hmm.
so if you've been broken into, there's three basic ways to address your workforce because, a mailman's gone rogue. And so it's like, okay,
Mm-hmm.
so you can just cut the workforce. So there's too many mailmen around and some of them have delivered their packages that have become plaquages in your arterial wall.
Mm-hmm.
So you can cut the workforce, and that would be a statin, right? Because
Mm-hmm.
statins decrease cholesterol synthesis, and then because they're
Mm-hmm.
decreasing the cholesterol synthesis inside the cell, your liver will upregulate more of those claw grabbers, the LDL receptor, to pull more in. Okay, so that's a statin. So you can do that. And statins, do some good things, and they can help stabilize coronary plaque. So there's that option, okay? But then also you can decrease the amount of spam mail that you're just going to throw away anyway. So there's less mailmen out there delivering the junk mail. That would be something called ezetimibe or Zetia. And so that decreases cholesterol absorption, not just from the diet, but also from a place where your bile duct meets the liver called the hepatobiliary junction, because there's something called Niemann-Pick C1 like 1 that is expressed there as well. Now, ezetimibe's very clean, very well tolerated, but it's just not very potent. And so, but if you use it in combination with a statin, if you're using a statin, you're going to get better benefit using two at once, hitting two different pathways, and you're going to minimize the dose-dependent side effects of the statin. So that's ezetimibe. So you can cut the workforce, decrease the amount of spam mail. And then the third basic way is to inhibit PCSK9. And so what you're doing with inhibiting PCSK9 is you're just making sure the mailmen go home at the end of the day. You're not decreasing synthesis of any kind. You're just enhancing clearance. And people who you could argue pick the right parents with PCSK9 loss of function, they don't have anything really wrong with them. They just don't get heart disease. And that's why those medications were made, because they looked at these people who, lacked PCSK9, and they're like, nothing really wrong with them except they don't get heart disease. And, so then of course pharmaceutical companies will try to go make several $1 billion off of that. And it's clever, it's clever,
Right.
But anyway, so that's kind of how those things go. And there's another kind of, it's kind of like a statin, but specific to the liver, called bempedoic acid. That's another tool that decreases cholesterol synthesis, but it doesn't get into your muscles and doesn't cross the blood-brain barrier. And so, that's a clever tool as well. So there's a lot of these lipid-lowering therapies as far as options, as far as, hey, you've been broken into. Do we want to get you living in a nice, safe, gated community with fewer criminals? I think that's preferable. But also, I think that we need to make sure that we're not just worshiping at the altar of high-intensity statins, right? Because we can acknowledge that statins do some good things. However, if you're going to use a statin, okay, the most bang for your buck that you're getting as far as reducing the corrupt mailmen is with your initial dose. Okay. With every subsequent doubling of your statin, you get maybe 6% additional LDL-C reduction, but you increase the side effects quite a bit. For instance, over 5 years, moderate intensity statin, okay, you get about a 10% increased risk of new onset diabetes. And I'm big on not having diabetes. Okay. 10%, that's not crazy, not so much more than your general population, right? High intensity statin over 5 years, 36%.
That's huge.
That's a lot. Okay. And so outside of acute coronary syndrome, where, you've had the big one, all hands on deck. Okay. The data is there for high intensity statin versus lesser intensity.
Yeah.
Okay. Different context, but we're trying to be preventive, right? And so I think being preventive also means, if I'm going to use medications, and so this is the if I'm going to use medications to try to get you living in a safer lipid neighborhood, well, do I want to jeopardize your home security system in the process? I don't. And so can I do that smartly by understanding a little bit about the interactions between our various tools? We can, because when you decrease cholesterol synthesis with a statin, your body's smart and it increases its absorption. How do we decrease absorption? Use some ezetimibe, right? And then statins actually increase PCSK9 levels. Atorvastatin 80, for instance, increases PCSK9 levels by 46%. Well, do we want a whole bunch of PCSK9 around? It's putting our claw grabbers out of order? Probably not. And so, all these things work in synergy and can work in synergy, right? And so that's kind of the point, I suppose, is when you've been broken into, your body fights you tooth and nail to keep living in this neighborhood because this is home, darn it, even as you're trying to move you out of it, okay? So if you can combine various agents, similar to what we do with, diabetes, if we're using medications for that, similar to what we do with hypertension when we're addressing that, we can actually, better mitigate the risk to your home security system and any of the side effects that might impair your quality of life, while getting you living in a nice, safe, gated community with fewer criminals. And I think that's a smart way to play the game.
Okay. Yeah, that makes sense.
So, what, from my perspective, and Andrea's too, but for my clients, like what kind of like supplementations are you recommending for people, and like what kind of dietary and lifestyle advice do you want, like somebody who's wanting to try um that first before relying on a
Sure, sure.
medication?
Absolutely. And honestly, if you pick the right parents and you pull the right levers across the lifespan, yeah, I don't think you have to reach for any of these things, which is great.
Yeah.
Now sometimes, you pick the wrong parents and you can have a perfect home security system and still get broken into. I have a good example.
Right.
I have a buddy who had elevated lipoprotein little a as his only risk factor. He had a CAC of 2,814, had to have a 5 vessel cabbage. He's doing great, but I mean, he just, his family history was
Mhm.
terrible, and he had the felon in his lipid neighborhood.
Mhm.
Well, crap,
Mhm.
and so sometimes, it's a fallen world, right?
Yeah.
But as far as supplements for, cholesterol itself, it's like, well, people sometimes will mess around with berberine or citrus bergamot and these things. I mean,
Mhm.
really though, what I'd say is, hey, just because you have a certain LDL cholesterol level, let's say your LDL cholesterol is 120 or whatever, and you're 48 years old. Okay,
Mhm.
got plaque? I don't know, get a CAC, right? And if you want to get
Mhm.
super sophisticated imaging, find somebody who does a CT angio, which will tell you if you have soft plaque and degree of stenosis. And, you could go get a carotid IMT with plaque assessment, and you could even do iliofemoral ultrasound. Detect disease, right? Because
Mhm.
just that, marker, it's associated with that, but it doesn't really tell you the whole story. And
Mhm.
honestly, the pharmacologic tools we have just are, they have more data as far as plaque stabilization, regression, and event reduction than any of the
Okay.
supplements you might be thinking about taking for your
Mhm.
cholesterol. My priority with lifestyle, knowing
Mhm.
that unless you do something pretty extreme, you're probably not going to influence the LDL cholesterol that much, but you can influence the LDL particle concentration
Okay.
by being less
Yeah.
insulin resistant. So my whole thing is, hey, don't be insulin resistant. Address the home security system.
Mhm.
Those things are much more modifiable as far as, hey, let's take care of our parameters of glucose metabolism. Let's look at what our blood pressure is doing. Let's look at
Mhm.
our inflammatory status. Most of the time, unless you have an autoimmune disease, the reason why people have elevated inflammation is angry fat. Well,
Right.
what can we do about that? Let's address that. And then if you're doing drugs, you probably should stop. And so those things are much more modifiable. And
That's not very sexy.
yeah, yeah, right. And so, and the thing is, it's like when I say
Mhm.
things, it's like, oh, what does this guy know? And really, what I say with this as well, prioritize protein, eat real food,
Mhm.
get awesome
Yeah.
sleep, and then move. And then lather, rinse, repeat your whole life. So it's like, oh, okay, well,
Yeah.
that's dumb. I didn't want that. Well, that's the answer. And
That is
so,
not what I was looking for.
Yeah, right. No, I
Where is
wanted a
the
magic
pixie
bullet.
dust?
I wanted
I know.
wanted
I
to
know.
take, plant scan balls or something. I mean, I was like,
Right.
whatever. You can mess around with stuff and whatnot, and all the supplements are interesting. I think supplements are really interesting.
Mhm.
I've probably tried most of them. At the end of the day, I take two. I take creatine and
Mhm.
magnesium. That's it. And so
Well, okay, listen.
yeah.
I want you to I want you to talk a little bit about a supplement that I have stopped recommending. Um that I used to in the cholesterol space. But that is and it's kind of the darling of, the lay functional audience is red yeast rice. I don't recommend it
Yeah,
anymore,
no,
but can
red
you
yeast.
talk about that?
Yeah, red
It's an
yeast.
HMG-CoA reductase inhibitor like a statin.
It's pretty much lovastatin. And
Mm.
so red
Mhm.
yeast rice, it's called monocolin K, is kind of the active constituent. It's lovastatin. The problem is
Mhm.
lovastatin's not very good anyway.
Right.
If you're
Right.
gonna use a
We don't use it
statin, use
anymore.
something better. Because lovastatin is pretty garbage and it has a lot more side effects than other statins that are available. Um,
Mhm.
and also, not only are you using lovastatin, which is pretty lame, you're using it and you don't know what dose you're getting. Who knows? It's the mystery proprietary blend of
Right.
lovastatin. And so who knows what you're getting?
Right.
And so red yeast rice. And so
Mhm.
people, I commend people for wanting to do things in a natural way or whatever, but
Mhm.
you're naturally taking a crappy lovastatin. And so, natural isn't always the best, right? You go out in the forest and you pick
Right.
a natural mushroom and then it
And
kills you, right?
amanita.
Yeah.
Yeah.
So, I mean, it's not always the
That's not good.
best. And so,
Mhm.
so I would say, hey, rather than mess around with red yeast rice, first off, have we done our diligence as far as our risk stratification and knowing your numbers and all
Right.
these things,
Agree.
getting the imaging. I really don't have any place for red yeast rice in my life.
Mhm.
I don't typically even eat a whole lot of just regular rice, although that's
Yeah.
fine. If the furnace is hot enough, anything burns. And, if you're
Right.
training hard
It's
enough to dictate, eating that,
Mhm.
then by all means do that. But anyway, yeah,
Mhm.
I'm not a big red yeast rice fan.
Okay. Thank you. Um Yeah, so let's see. Ashley and I were really kind of keen to hear you talk about. I personally, I know you from several meetings, before we had you on the podcast in a professional space, and you and I have had the chance to talk a little bit about, your research areas and what you're really interested in, and your areas of passion and so forth. But we had some great discussions about glucose management and cognition and dementia and Alzheimer's. And I know that that is a special interest area of yours. Could you kind of tease a little bit of what you've been learning as of late?
Yeah, yeah. So this is a great topic, and some of the things I brought up as far as the LDL receptor and PCSK9 was mainly to
Mm-hmm.
give enough context to where we can sort of start to make sense of the complexities of
Mm,
lipids in the brain. So to start
mm-hmm.
off, my home security system, that holds true for anybody, whether you're talking about cardiovascular disease, whether you're talking about brain health. Last year, there was a publication of like 14 different factors that are related to Alzheimer's disease. And, a lot of them were don't smoke and, diabetes and
Right.
obesity,
Mm-hmm.
sedentary lifestyle. Oh boy, that's never your New
Mm-hmm.
Year's resolution is to move less,
Right.
right? And so all these things are pretty basic, but at the same time, really important, you know? And so there's all these things that go into, I would say, the home security system part that are super, super important. Because what we
Mm-hmm.
see in people who go on to develop Alzheimer's is way before they have symptoms. They have glucose hypometabolism, when they're doing these various scans. There's lysosomal derangements. There's also, there's just impaired substrate utilization,
Mm-hmm.
just because although it's a really complicated discussion of glucose derived lactate and ketones, glucose is a very important fuel source for your brain, particularly your neurons. And so, whatever
Mm-hmm.
you can do to utilize your savings account, which are fatty acids below the brain, to preserve the glucose for the brain, I think is super important. Because if you're not using glucose well in the brain, people will say, oh, you're starving your brain. It's not really starving the brain, but at the same time, when you aren't utilizing fuel appropriately, your mitochondria aren't going to be as efficient, and there's going to be problems when all these processes, which usually are regulated very, very well, when you're a well-oiled machine, starts
Mm-hmm.
to get the work gummed up. And
So take
so,
us,
yeah,
Josh. Can you take us from kind of walk through for a lay audience from hyperglycemia, elevated A1C, right? Elevated fasting insulin, elevated fasting glucose. Take us from that insulin resistance to physiologically what how do we get from that to dementia?
yeah. So, and this is interesting. And so basically, I would say that insulin resistance, fasting glucose, prediabetes, diabetes, it's all like being almost pregnant, right? It's just a matter of how far
Mhm.
along you are in the process. Okay.
Right.
And so, what I'll say is that if you and I didn't eat for like 3 or 4 days,
Mhm.
you'd suck at CrossFit if you went to try to go do that because you require some
Two?
glucose for that sort of fuel. But your blood sugar would regulate right around 60 to 70. Why is that? It's because your liver, produces via gluconeogenesis the glucose you need. and it passively diffuses via something called the GLUT1 transporter into the brain. And so glucose is a precious, precious commodity for the brain to keep the brain running. That's kind of the priority, because if your brain isn't running, you're not you. There's a big difference between living and existing. Now,
Right.
can your brain use ketones? Yes. And when you're in a state of ketosis, it will use more ketones because they're there than normal. But will it still be using glucose? Yes. And so and there are variances on between cell types as far as astrocytes and glia and neurons as far as what they're doing with fuel utilization. But at the same time, the more efficient we can utilize our fuel, the better. Because if you're not utilizing fuel well, there's going to be little fires that start in your brain. And, we have genetic factors that basically regulate how good our fire department is at putting out those little fires. And so the solution for me is just don't let the fire start.
And
And
that's
then, and
inflammation,
then,
right?
yes.
Like
And yeah, and
neuroinflammation.
reactive oxygen species and other things.
Sure.
And honestly, a lot of it is toxic lipid accumulation.
Mm.
Alzheimer himself, one of the first things he noted in people with Alzheimer's were these toxic lipid droplets in these people with cognitive impairment. And so it's one of those things where, under normal circumstances, hey, we're utilizing fuel appropriately. And then our lipid delivery system in the brain, which I'm going to go into in just a sec, works perfectly well. But in the context of, I would say, an impaired home security system in a lot of ways, then you're not going to be able to be as mitochondrially efficient. You're not going to be utilizing fuel appropriately. And then you could run into some of the lipid disturbances that we see in people that go on to develop Alzheimer's and people that do have Alzheimer's dementia.
Okay. Okay.
So I should probably just do that. So here's the thing. So there's a million different characters, and at one point during my PhD, I think I had a list of like 200 different lipid characters that were potentially relevant in Alzheimer's disease.
I
And
am
what
not surprised.
it's
Yeah.
ridiculous. And so
Mm-hmm.
what I have boiled it down to is three main buckets of cholesterol
Okay.
disturbances that we see consistently in people with Alzheimer's disease. Okay. The first one is impaired cholesterol transport. And this is related
Okay.
to something called ApoE. And I'll go back to that in a minute. The first is impaired cholesterol transport. The second is impaired cholesterol elimination. If there's excess cholesterol, well, we want to have a way to get rid of that. And the neurons have one way to get rid of it. And if they're not getting rid of it, then we have toxic oxysterols that develop. And then the third one is impaired cholesterol synthesis. Yeah.
Okay.
So you have these three buckets. So the first one is decreased lipid transport or decreased cholesterol transport. So the brain is separate from the rest of the body. There are no ApoB particles usually in the brain, and so they're not supposed to be there anyway. When they are, that's correlated with cognitive impairment. But your primary lipoprotein in the brain is an ApoE HDL-like particle. Okay. And
And this
so,
is what people are familiar with the genetic testing, right? They've
yeah,
got
because
this, these SNPs for
mhm.
ApoE. Yeah.
Yeah, so there's ApoE4, there's ApoE3, and there's
Mm-hmm.
ApoE2. 75% of people have two copies of ApoE3. So you're a 3-3. If you have one copy of ApoE4, then you have maybe a 2 to 3-fold risk of Alzheimer's disease, just across the board. And then if you have two copies of ApoE4, which Chris Hemsworth, ApoE Thor,
Right.
maybe he has two
Yep.
copies. And that's why this has gained some awareness because, I mean, the dude looks like he
Yep.
descended from Mount Olympus, right? But he,
He
has
sure
this
does.
heightened
Yeah.
genetic risk of Alzheimer's. Now, here's the thing. I don't actually think he'll get Alzheimer's because he knows he's pulling the levers aggressively. And it's not a deterministic gene. There was one publication that tried to say it was last year, but I don't believe that. Because there are multiple factors that go into this charade, but it means you have very little
Okay.
margin for error. Okay. So you
Right.
better get on it and you better do things right across the lifespan, or else you're probably going to have a protracted demise if you have two copies of that ApoE4.
So your
Now,
epigenetics have to be on point in order for you not to express.
yeah, the phenotype, yeah. And so, I'd say
Mm-hmm.
that so that comes down to like a lot of lifestyle stuff, I would say across the
Mm-hmm.
lifespan. Now, typically what happens is your astrocyte, so there's various cell types in the brain, right? Brain's ridiculous. So the astrocyte though is what produces cholesterol, and then the cholesterol is exported out into this ApoE particle. And then the ApoE delivers it to the neuron. And then the neuron utilizes cholesterol for all the wonderful things it does. Because really, cholesterol is
Mhm.
expensive to make. It takes a lot of ATP to synthesize cholesterol, and the neuron's got other things to do, right? The neuron's like the busy
Right.
executive, and it's like, okay, it's running the show. And so if the astrocyte and the support staff, does their job, and then the ApoE, which kind of just delivers the memo to the executive's desk, gives it to the
Mhm.
neuron, and it's like, great, I'll sign that and then go on and keep running the show. That's what's supposed to happen.
Mhm.
Problem is, the ApoE4 particle is kind of easily distractible. So instead of taking the cholesterol that the astrocyte made and delivering it to the neuron, it's like, oh, maybe I'll go bind to something else, and then the neuron doesn't get the memo. And then the neuron's like, what the heck? What's wrong? I'm not getting the messages. So then the neuron tries to do everything himself. And a neuron can make ApoE, but it shouldn't. And that's a sign of a stressed neuron. And then it's one of those things
Hmm.
where if everybody
Mhm.
isn't doing their part in a busy office or corporation or medical office or whatever, it's going to lead to burnout. And so what happens is there's compensation going on, but then there's all sorts of problems. And eventually, this leads to some of the issues we see that lead to eventual cognitive impairment. And so
Is that
when,
neuronal
yeah.
death? Is that
Oh yeah,
neuronal
yeah, yeah.
death at
Yeah, and
the
so you
end?
can get neuronal
Okay.
death. And
Okay.
what happens before that is you can get these lipids accumulate. So if they're not getting delivered, the cholesterol's not getting delivered, well, where are they going? They're just hanging out and they're not supposed to be
Mm.
there. And so what happens is you get this oxidative modification of the cholesterol that should have been delivered to the neuron. And there are things called 7
Mhm.
keto cholesterol, 25 hydroxy cholesterol, toxic cholesterol metabolites that are just sitting there. And then when there's toxic cholesterol metabolites, what happens? Well, that downstream leads to amyloid beta peptides and then tau
Okay.
hyperphosphorylation and neurofibrillary tangles and the things we see in Alzheimer's. So in my view,
Mm.
really Alzheimer's and the things we see, because it's an amyloidopathy. Those things are a
Mhm.
downstream consequence of impaired substrate utilization and then the lipid disturbances that we see rather than being the thing that we should go after. Because right now
Yeah.
there's only a couple
Yeah.
medications and they're anti-amyloid antibodies.
And they don't
Okay.
work.
I mean, if you want your brain to bleed and swell, here's the thing. So I'm never going to say that no medication is completely useless, except maybe sulfonylureas. But, there's actually one type of monogenic diabetes of the young that is sulfonylurea sensitive. Anyway, stop. Just forget I
Okay.
said that. But
Okay.
but at the same time, do I think that that's the right approach? I don't. Because
Mm.
under normal physiologic circumstances, the synthesis rate of amyloid beta and the clearance are virtually identical. In fact, clearance is a little bit greater.
Mm.
And so it's one of those
Hmm.
things where, I think that's too late in the game. And the people that get the amyloid related imaging anomalies, which is ARIA, that's the big side effect where you get cerebral edema and microhemorrhage. Who are they?
Okay.
ApoE4 carriers. And these are typically the people we're
Oh.
going to be trying to do something about anyway. So I'm not real optimistic about that approach.
Mhm.
I'm more optimistic that we are having biomarkers that are giving us better
Mm.
understanding of what's going on there in the brain and
Yeah.
intervening earlier. And if we do need to use medications, I think it's going to be a metabolic and lipid related cocktail
Mhm.
rather than just trying to blitz
Agree.
amyloid. Um,
Yeah.
and so I'm actually quite optimistic that that's going to be possible in the future.
Cool.
We just need to know a few more things about some of the lipid characters in the brain to give us a little better understanding of what to do about that. Additionally, something else that I mentioned was the decreased cholesterol synthesis that we see in the brain. So when
Mhm.
there's these oxysterols that are accumulating and not getting eliminated, well, it actually negatively feeds back on cholesterol synthesis. And so across the board, we see
Mm.
decreased cholesterol synthesis in the brains of people with Alzheimer's disease. Well, do we have a biomarker of that? Maybe. There's something called desmosterol. So if you go and I know Boston Heart Diagnostics has markers of cholesterol production and
Hmm.
absorption. So the two main
Mhm.
markers of cholesterol production are desmosterol and lithosterol because those are the penultimate precursors of two different pathways that ultimately result in cholesterol synthesis. And so you can get that, and you can get those markers. And then for absorption, there's campestrol and sitosterol. And if those are elevated, then that person probably benefits a ton from ezetimibe, actually. But anyway,
Mm.
so in the brain, there's something called the block pathway, which primarily has desmosterol as the penultimate precursor. And there's an enzyme called 24 dehydrocholesterol reductase that converts desmosterol to cholesterol. That predominates in the adult brain. And typically, lipids below the brain don't correlate very well with what we see in the cerebrospinal fluid at all. But in this case, they do.
Oh, okay.
So, desmosterol actually correlates quite well when we see it in the plasma with levels in the brain. And
Oh,
we've
okay.
seen in a couple different studies, the Helsinki businessman study, and then there was another Japanese cohort where low desmosterol levels were actually a prognostic for Alzheimer's disease. That's interesting, right?
Huh.
Now, knowing that of all our tools in our toolbox, the only tool that we have right now that crosses the blood-brain barrier is the statin class. Well, that's interesting. Now, at the population level, is there any negative association with statins and Alzheimer's disease? No. But could, if this ends up being, a good marker of cholesterol synthesis, and knowing that
Mm-hmm.
statins decrease cholesterol synthesis and do cross the blood-brain barrier, if someone has
Mm-hmm.
low desmosterol levels, could we maybe think about maybe other ways to address their ApoB below the brain? I think that's
Mm-hmm.
at the very least quite reasonable. But at the same time, there's a lot we don't know, right? It's interesting
Yeah,
stuff. No statin
that
trial has
is
ever been
interesting.
powered for reducing dementia or Alzheimer's disease. Vascular dementia is a different entity, and there seems to be
Right.
probably some more benefit there if you're talking about statins. But at the same time, we have multiple tools in our toolbox, right? And
Mm-hmm.
so my
Mm-hmm.
take is, hey, I know really well what I'm doing below the brain, like super well.
Yeah.
There's a lot we don't know about the brain. I think it's knowable, and we need to better understand, I think, the role of things like, PCSK9 in astrocytes and
Mm-hmm.
glia in neurons at various stages of disease progression, because PCSK9, interestingly, is quite elevated in people with Alzheimer's, in
Hmm.
CSF and serum, more in ApoE4 carriers, more in women in certain studies. So there
Wow.
might be some differences there too, male versus female. So really interesting stuff, right?
Yeah.
But I
Yeah.
think it's knowable. That's what excites me. It's just a matter of getting people
Mm-hmm.
to, run the things and look at these things. And so, but anyway, until we have a better idea, though, exactly with precision of what's
Mm-hmm.
going on up there, I prefer to stay below the brain when it comes to addressing your lipid neighborhood. And that's because we have a real
Mm-hmm.
good idea of what we're doing down there. And there's a big association between cardiovascular disease and Alzheimer's disease and other forms of dementia. And so if
Right.
we can address the cardiovascular disease, which I feel very confident in that, knowing how lipids work below the brain, then I
Mm-hmm.
prefer to do that while we figure out or try to figure out what's going on upstairs. So anyway,
Yeah.
it's super
Yeah.
interesting. Hopefully that, and what I like to do though is give people hope, right? Leave them hopeful.
Right.
It's not like, oh, well, you got ApoE4, you're screwed, right? No,
Mm-hmm.
actually, I actually would want to know. My wife has one copy, but really, do I think she's going to get Alzheimer's disease? I don't, but I
Yeah.
think it's a good thing to say, hey, I've got less margin for error. And so I'm going to do everything I can across my lifespan to,
Yeah.
have the home security system in working order. And so anyway, that's kind of my little take on lipids in the brain. If you are struggling with insomnia and you want several hundred pages, I have a dissertation I can help you with. But most of the time, I try to maintain my friendships and keep people
Right.
conscious. But it is a really fascinating discussion, and I hope it gets
Yeah.
people excited, and I hope
Mm-hmm.
it gets all of us in this space excited about potentially having a future where we have far less Alzheimer's disease.
I love it, man. This was I feel like this just kind of brought everything together so perfectly. And
Mm-hmm.
I, Andrea and I are all about like, what can we do on a lifestyle front before we do these medical interventions? So I really appreciated how you brought that all together. And again, I just like
Yeah.
how the analogies that you use in your book. So, um, Josh, thank you so much for joining us.
Yeah, and Josh, can you tell folks where to tell all the places that they can find you and that they can get your book? I highly recommend it. I have read it. Ashley's read it. We have received an advance copy. Thank you, Josh, and I'll be ordering a desk copy as well. So yeah, I really appreciate that. It's fantastic. I think you'll get a lot of benefit out of it to our listeners. But tell them where they can get it.
Yeah. So if you just go to Amazon and you search the home security system and the Lipid Neighborhood, it'll pop up. The only option for pre-order is the ebook, which is fine. I think the ebook's a nice reference for like clinicians, or if you're somebody who really likes the Kindle, that's fine. Just because there's also references there you can go to. It's like, oh, what's the percentile of ApoB here? Oh, there it is. But at the same time, I think the paperback's where it's at. There's something about sitting with a book. And the way
Agree.
I've written it,
You
you
can
can read
highlight.
it as a story, but also at the same time, it can be a reference as well. I don't think you've ever read anything quite like it. And so I want people to laugh a little. I want you to learn a lot, and I want you to be better off than before you started reading it. And that's the whole goal. My goal is not for this to be some sort of lucrative, crazy thing. I just want people to read it because I legitimately want people to not have heart attack, strokes, and dementia, and make just better understand some of the things that go into this. So it's going to be like $14.99 for the paperback. The
Great
ebooks
price
like
point.
$9.99. So hey, if you skip your Starbucks for a day, you could probably go get that.
Right.
And then you can
You
go
don't need
back to
many days.
Starbucks and read it there if you want.
There you go.
Yeah.
Anyway, that's kind of my goal. And then if you want to wax esoteric on some lipid things, I'm on X, formerly known as Twitter, at Josh J Wageman. You can search me on LinkedIn. I don't usually do a whole lot on LinkedIn, but I'm there. There's a little picture of me, so if that rocks your world, then cool. But
Oh, that's awesome. Well, I'll put all that information in the show notes. So scroll down a little bit and click on it, and definitely get a pre-order for this book. Highly recommend. And who knows, maybe we'll have Josh on in a future episode to dive more into all of this. If you have questions, or if you are like, oh my gosh, can you expound on something or touch on this, then please send us an email. I'll put our contact information in the show notes too, but also with Josh being his contact information in the show notes, hit him up as well. I'm sure he would love to hear from you as well. So again, thanks Josh for coming on.
Thank you.
Yeah, this was just a really great episode. I know so many family members that have been wanting some simplified information on this. So I think this will be a massive benefit for them. So, and I think that concludes today's episode. We will catch you on the next one.
Bye-bye.
The content provided in the AA podcast is intended for informational and educational purposes only. The podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The information and opinions expressed in this podcast are solely those of the individuals involved and do not constitute medical advice.